Hello and welcome to Global Medical Education CPD Webinar Series. My name is Professor Naseem Naqvi. I work in Blackpool. I'm an acute physician and also a stroke specialist. I have with me the program coordinator, Dr. Mansoor Ali, who is a consultant renal physician from Bradford and also honorary senior lecturer at University of Leeds. We host these webinars once a month, inviting specialists, experts from around the globe. And our last couple of webinars, we have seen doctors from at least over a dozen countries, 14 countries last webinar. And we discuss important topics, a wide range of specialties, speakers from UK and also globally. And I'm very excited, very happy today to have two excellent speakers, Dr. Stephen Gulliford, who I've known for many, many years. We trained together in Wigan in 2006, 2007. So I've known him for many years. And also very excited to have Professor Derek Bell today, UK's first professor of acute medicine. And he has been our mentor and a guide for over so many years. And one of the reasons why I decided to pursue a career in also in acute medicine because of people like Professor Derek Bell, huge inspiration for all of us. So I'm very grateful to both of our speakers. So first we have Dr. Stephen Gulliford, who is a consultant acute physician in Wigan Infirmary, Royal Albert Edward Infirmary in Wigan, in the northwest of England. So over to you, Stephen. He's going to talk about acute medicine in district general hospitals. What are the challenges and opportunities? Thank you.
Thank you very much, Naseem, for the introduction and for inviting me to talk this evening. So for the next 15 minutes or so, I've got a few slides to take you through. As Naseem said, my talk really is acute medicine in the district general hospital. I have to say there's probably a few more challenges to discuss than maybe opportunities, but hopefully we can get the opportunities in there as well. So this is where I worked with Professor Naqvi a few years ago. You might recognise this as the good old Royal Arbiter Infirmary in Wigan. We serve a population of about 340,000 people around the Wigan borough, stretching often to the west in Merseyside, sometimes up into Lancashire and across towards Bolton. So it's quite a large catchment area. The Trust has actually recently acquired teaching hospital status just before the COVID pandemic. So partially we're still a district general hospital, but we've certainly started to do a lot more with the local universities now around Liverpool and Edgehill University as well. But I think it's still very relevant for me to consider myself as a consultant physician in acute medicine in a district general setting, with us being probably about 20 miles or so to the northwest of the centre of the city of Manchester. So in our hospital in Wigan, the Royal Albert Infirmary is the only real acute site of the 3 hospitals within the Trust. On the acute side, we have about 450 acute beds. Now, when I say 450, this spans mostly medicine, but this includes obviously a couple of surgical wards as well. But as I'm sure occurs in most hospitals of this size across the country at the moment, those surgical wards are at least half occupied by medical patients, aren't they? Drilling down to the actual acute medicine department, we have our AMU, which is split across 2 wards and constitutes 53 beds. We have an SDEC department, which is actually, in one respect, COVID did us a favour with this, because we got a lot of extra money right at the start of the pandemic to build an extra ward that we never actually really used for COVID, but now it's with us, and that's become our SDEC department. So we've got a nice, spacious, large SDEC department. And I do wish I could go on and on about SDEC. It's a real passion of mine, ambulatory care and SDEC, but that'll probably be another talk, maybe another time. Our department as well, we work on the emergency department as well, and InReach. So I think I'm right in saying probably still we're fairly unique. I certainly know we are around Greater Manchester in regards to most of our work after the morning ward rounds on AMU is done actually in the emergency department, and the juniors in our hospital actually see the acute physicians as one and the same team almost as the emergency physicians. And we try and make sure that all the time we're managing our patients by the right person on the right pathway right from the very start. Before I go on to our take as well, so numbers wise, just to give you a scale of what we are and what we do very quickly. When I started as a consultant there, I was the second whole-time equivalent acute physician back in 2011 in the trust. Now, I was CD for about 5 years, clinical director. Now I've handed that over a couple of years ago. But the current clinical director is now the line manager for 13 consultants. So you can get a picture of how the specialty has grown, and I think that's represented in our DGH as well. One of the opportunities of working in a district general setting, I think, is the unselected take. You might not necessarily get this to the same degree, I think, in teaching hospitals or larger trusts. By this, I mean everything comes to medicine, everything comes to acute medicine, but we get to see all the acute MIs still, you know, apart from STEMIs, which I'll come on to. We get to see all the acute chest pathology. We basically get the traditional mix of acute patients. And I think that's one of the real opportunities of working in a district general setting and one of the benefits of it. With regards to junior training as well, and I've got the references to share at the end, it's quite interesting when you look at opportunities that are presented to junior doctors and trainees in a district general setting. I do think with foundation training over the last 10, 12 years or so, and with the way IMT training has gone, that it's sort of leveled out a bit, perhaps, between teaching hospitals and district generals, particularly when you're working in acute medicine and working on take. And there was some good research there to say that actually the opportunities are pretty equal. I think you can still talk to trainees and talk to medical students, and they may think that coming to work in a small hospital in Wigan may not present them with the same opportunities to learn how to do procedures, to do specialist clinics, etc. But actually, when the research is done, it shows that they're pretty equal, the experience they get and the opportunities they get working in a larger teaching hospital setting. I think with it being a small hospital, one of the opportunities as well, from a junior point of view, is the fact you get to know your consultants. It's quite a community feel about the place. It's very small. Everything's very much next to each other. You see a lot of each other. You see a lot of consultants coming in and out of AMU, and you get to know them. I think that builds relationships, and for the time they're there now, they get more ability to approach consultants for teaching. They get more chance to do things sort of out of the timetable as such. And I think that's certainly an opportunity to bear in mind when you're looking at applying for jobs and looking to perhaps work in a smaller setting, smaller hospital. For consultants, I think also there's quite a lot of opportunity working in perhaps a smaller trust. But when I say smaller, so I've got to point out, Wigan has won lots of awards as a trust over the last few years as well. So it's certainly not an underperforming trust, even though it's small size comparative to other trusts in Greater Manchester. And I think if you're looking for consultant jobs in acute medicine, that's worth looking at as well. There's lots of opportunity from very senior managers that work in the trust to support you, and from senior consultants working in the trust as well to develop yourself and develop things very quickly. In a smaller hospital where there's fewer consultants around, there's more opportunity to lead services and actually, you know, take charge and develop services very early in your consultant career, and perhaps earlier than the opportunities may present themselves to you as an individual in a larger teaching hospital. Now, the challenges that we face. So Wigan is a bit sort of out of Greater Manchester, if you like a couple of the other district generals, and recruitment is very difficult. It's not where people tend to live near, and that does influence where people apply for jobs, I think, particularly when trainees are looking at jobs to go to. We need to provide a lot of incentives, and one of the things we've done is we've got very innovative rotas, which I don't think you get elsewhere, where our frequency is actually quite intensive at first glance, in that we do a 1 in 6 on-call rota, but there's about 11 consultants in at the weekend. So we're covering AMU, different people covering A&E, different people covering the outlying wards, and specialty input from on-call rotas from gastro, cardiology and chest. So there's a lot of support from your specialties there, even though it's a small hospital. There's a lot of support on call as well. And we need to do things like this to enhance recruitment. And by the figures I gave you right at the start, where I've gone from me being the second one to now having 13 consultants, it's not 13 whole time, but 13 colleagues working in the department, shows you actually that these things do work, where you offer people attractive job plans and the opportunity to take services forward. People want to come and work here. As a hospital, we're facing the same challenges as probably large teaching hospitals do. We're in a district general setting with our relatively low bed base, the small bed base for the population we serve. One of the big challenges to us is the aging population. So in the Wigan borough, the number of nursing home and residential home beds hasn't increased by 1 bed in the last 10 years or so. However, the number of patients over 75 with complex comorbidity presented to our hospital and presented to our acute medical take has exponentially increased. So that mismatch puts pressure on the acute medicine departments, and that's one of the big challenges we continue to face. I'll say one of the biggest challenges working as a consultant in acute medicine in a district general setting is what I said earlier on in this, the old adage that everything comes to medicine. So a lot of tertiary services went out of the hospital. So vascular surgery, for example, went up the road to Preston. Well, our 2 vascular surgeons retired from the hospital, weren't replaced, and there's no vascular surgery on site. Now it gets even more complicated for us because that's vascular surgery that deals below the diaphragm. If you have a vascular problem with your aorta above the diaphragm, then it's either Blackpool or it's Wythenshawe or it's Liverpool Heart and Chest Hospital. And these hospitals tend to share different rotas between them. It's quite complicated when you're an acute physician or you're an emergency department physician and you have a patient with a problem, an acute vascular problem, and getting them into one of these beds. Some centralisation works, and I don't want to appear as if I'm a complete opponent to it. Some centralisation works, and there's evidence based in the research to show that it improves outcomes, improves survival. So if you have particular conditions such as primary PCI, such as stroke, and you go to central Manchester, you go to Salford Hospital, we know your outcome will be better than if you're admitted in a district general setting and receive standard therapy, that within the limits we can provide there. However, I think the pathways like primary PCI, like stroke, work because these patients are picked up by the paramedics in their home. The paramedics tend to identify possible stroke, possible STEMI, and take these patients to the right hospital. There's no discussion over the phone, there's no waiting a bed, there's no is it, isn't it, shall we do some more scans first? They go there, and that's how it works. I think one of the challenges we face is where the pathways need more work, and actually where there's difficulties with bed availability, so the patient stays in the district general in Wigan waiting for the specialty bed. Sometimes they deteriorate whilst they're waiting and are no longer fit to transfer. And I think there's an argument to say that that isn't the best for our patients, and that's something that needs further work. It's definitely, I would say, the biggest challenge, and a challenge that's only going to increase over the next few years for district general hospitals as more services are centralised for cost and for evidence-based medical reasons as well. So I think I finished a few minutes before there, the team. My 15 minutes allocated, but these are the 2 references for, I'll leave on the screen for a second for people to take down should they want to.
Thank you very much, Stephen. Yes, thank you. That was an excellent talk. We have a couple of questions we'll take in the end. So I think we can invite Professor Derek Bell slightly early. So we have our next speaker, keynote speech from Professor Derek Bell. We're really honored and grateful for Professor Bell to come and talk to us today and for his time. Professor Bell is UK's first professor of acute medicine, and he is also a life fellow of Society for Acute Medicine, one of the pioneers of acute medicine in the United Kingdom. So he's going to give us an overview and his thoughts on pursuing a career in acute medicine in the UK. We have lots of junior doctors, trainees, and doctors interested in pursuing a career in acute medicine. So any tips, advice, suggestions will be very, very useful. So thank you very much, Derek. Over to you. Thank you.
So can you see my screen yet? Can you see my screen?
Yes, yes.
We need to see these slides, yeah. This acute medicine as a career, is that what you can see?
We'll see, we are seeing, yeah, that's right. The first slide, yeah.
Okay, so first of all, thank you very much for the invite and the opportunity to speak to you. There'll be a little bit of overlap with Stephen's talk, which I think is a good thing, because it's quite important that we generally agree on the challenges and the successes of acute medicine. But I'm going to sort of probably talk a little bit more around it more generically, and some of the training opportunities that might apply. As you've just heard, I'm sort of in the twilight of my career. I've just hung up my stethoscope back in December 21. Did my last series of weekend days as an acute physician, but after a good few years on the shop floor. So hopefully this will still be relevant. And I think I'm not going to go into the history of acute medicine, but from one of the two of the questions that have propped up, I suppose one of the big challenges that we faced right in the beginning was why develop acute medicine at all. And I'm not going to go into that in detail, but the important thing is that the reason that we developed acute medicine still holds true today. And Stephen sort of highlighted elements of that. It's about doing the right thing for the patients, providing the right environment, providing a training environment, and trying to avoid patients being scattered everywhere in the hospital without first at least having a good assessment and a good navigation to the bed that they should be in, as well, of course, as getting patients home. But we should never look back to the good old days, because the good old days were never that good. They had their own problems. But acute medicine was really born out of trying to develop a quality service. And here are the kind of main reasons for that. That high quality clinical care I've talked about. But the other thing I think is fundamental to acute medicine, and has always been an ambition for the Society for Acute Medicine, is it should be multi-professional. And certainly that means including advanced nurse practitioners, allied health professionals, of a range of allied health professionals as part of the team. And that's because you're trying to surround the patient with the team that helps them in terms of getting the right diagnosis and the right treatment. I think acute medicine's got a huge part to play in how we use digital, and that leads a little bit to what Stephen was talking about same-day emergency care and ambulatory care, which I'll touch on. I think acute medicine provides a fantastic education and training environment, particularly for medical undergraduates, but really at all stages of career. And again, I'll touch on that. Research and innovation, we can be doing a lot more. Therefore, that means for people entering into acute medicine, the opportunities are still significant. And as from part of the conversation today is actually acute medicine is developing and does have an international footprint. How it's grown in countries does vary. But again, going back to some of the challenges will always be, political, either at a government level or indeed from within the healthcare profession. And you do need to be cognizant of that as you develop acute medicine or even choose a career in acute medicine. So the core components of an acute medical service, and this is relevant to training, is, and again, Stephen said this, it's the ability to manage acute unselected medical emergencies. That's the key part. And even in a tertiary or a quaternary referring hospital, you're still probably going to be, acute medicine is still going to be in a position to probably manage 70 to 80% of all individuals admitted to hospital requiring medical care, but excluding areas like stroke, acute myocardial infarction, as Stephen mentioned. I also think that acute medicine should have an area where it can look after the sicker subgroup of patients. That could be a high dependency unit, or it could be a level 1 unit, which is just below high dependency. But that offers the ability to manage people to a ceiling of care where that's appropriate, or indeed to as a staging post to work out, will they require HDU or ITU, but not to delay the care, but just to make sure that they have the right care. You've heard about ambulatory care. I'll come back to that. Acute medical clinics are another option. and probably fall into the broader category of acute medical care. And as units grow, they will actually develop outreach or other support services, but that needs to be done within the not the footprint, but within the human resource element that makes it feasible to deliver a safe service. I'll put down a reference there, looking at some of the different models that are available that some of you might wish to look at as well. So I've mentioned the growing international footprint. I think from a training perspective, that is important. And, you know, in terms of areas that I know that are definitely developing acute medicine, Australia is much more of an acute medical unit model than true acute medicine. Bangladesh and Pakistan are certainly developing acute medical units and planning to train. Malaysia's got training, Ireland's got training, Singapore has acute medical units and acute medical consultants, and has again got a growing reputation across all the hospitals in Singapore. So the opportunity there is actually, how do we bring the learning from the different international groups together? How do we look at the different training needs they have, and how do we coalesce that? So for instance, in Malaysia, a particular element of that has always been near bedside ultrasound. They focused on that at a very early stage in their training program. Research and audit, I think, for trainees or people going into medicine is something that definitely provides an opportunity, and there's lots of reasons for that. Acute medicine will have a recognised mortality, probably between 3 and 5% of people admitted through an acute medical unit, not necessarily will die on an acute medical unit, but will probably die during their hospital stay. It's an opportunity to catch comorbidity, and the SAMBA audits and do that well. But in the post-COVID area, there's going to be opportunities for looking at how patients are presenting going forward after either a delayed non-COVID presentation or post-COVID surveillance. We'll also definitely have an increased workload, and I think we're seeing that in the UK at the minute with admissions and AD attendances again getting back to almost record levels, at least in England. And I've mentioned there are other national audits, but I like SAMBA and getting it right first time, which provides support, but also an opportunity for research and innovation. And the reason I mentioned research is that because it's still an area as a growing specialty, and it is a mature specialty now, research becomes an important part of its training and development work. And you can see that in the Society for Acute Medicine, and I'll come back to the number of attendees. But the number of posters, the quality of presentations, the quality of papers is improving year on year. And that, of course, is dependent on an active group of consultants, but also trainees getting involved and being part of their portfolio to try and aim for 1 or 2 research papers, or at least abstracts during their career. I've talked that there's a number of publications, there's quite a lot of publications around acute medicine, but one of the things that is important, and Stephen's again mentioned this, is actually how we construct rotas in acute medicine. We've got to make acute medical rotas family friendly, we've got to make them patient friendly, we've got to deliver as much continuity of care as we can in those rotas. And the evidence is the more that we provide continuity of care in an acute medical unit, the more likely you are to get better patient outcomes. And therefore that does depend, as Stephen's already alluded to, on designing attractive rotas where the work demand is appropriate, but we're also making sure that we provide the best quality of care. And again, that does include the multi-professional nature of the team. And again, this is again where the power of data. So I would encourage any acute medical unit to make sure that it had good data analytics support on a regular basis. And if you can get junior doctors or others involved in data collection, even better. But data provides power to any specialty, providing the data is collected well and it's appropriate to do that. If you collect data well, there's opportunity for collaborations with other countries. And one example would be that we looked at the acute medical responses in Singapore, Netherlands, and in England recently, and that's been published in terms of how did systems respond to COVID. And there was lots of similarities, but there was also lots of differences based on when COVID hit, what their previous experience was of pandemics, etc. So if you have data, you can automatically begin to have discussions with other organizations or other countries. But that local data is important in terms of peer pressure and peer support. And that goes down to appropriate morbidity and mortality meetings that can encourage reflection and learning. The other area that I think that is ripe in acute medicine is getting involved in quality improvement, whether you call it improvement science or quality improvement. I don't really mind, but there's huge opportunities for service redesign still in and around acute medicine and related specialties that we interact with. Just a little bit for me around acute medical units in terms of training. By definition, they're short stay units, and that length of stay may vary, but it's certainly going to include 0, 1, and 2 lengths of stay for the majority of acute medical units, or indeed acute physicians. What they aren't is triage units, and that I think is vitally important, as they don't just become somebody who signposts somebody to another service. For a subgroup of patients, acute medicine will and should provide all the care that is needed that leads to safe discharge or safe onward referral. I'm going to do a little bit about, I'm just going to mention acute medicine, because one of the drives for acute medicine, apart from providing quality of care, is that it should support shorter length of stay. It should help avoid unnecessary admissions. But that does mean that we need to understand the metrics that goes with it. And this isn't a criticism of anybody. It's just that readmission rates need to be thought through, whether that's in ambulatory care or whether it's in acute medicine per se. And what this graph shows, and we've known this, is that most readmissions to hospitals, certainly in the UK, if you're going to be readmitted after an emergency admission, then you will most likely to be admitted within 7 days, and actually most likely to be readmitted within about 3 days. So having an early marker for readmission, like 7 days, should cover elements of acute medicine. If we wait to 28 or 30 days, yes, there'll be more patients readmitted, but you can see that the numbers begin to tail off over time. So acute medicine is really working in this area here, in the sort of 0 to 72 hour length of stay. But what we want to be able to do is ensure that we can measure, have some metric for our readmission rates, and some will be unavoidable. That's just what happens, but we should be cognizant of it. And the point I'm trying to make here is that if you look at readmissions to hospital in NHS England, then I need to move my thing here. You can see that about 15% of readmissions are contributing to the overall rise. And this, basically, it's a significant chunk of hospital admissions. It's about 1/3 of the total increase in hospital admissions over the last 5 to 10 years relate to readmissions. So if we're going to provide a quality service, it needs to be a safe service. And just to put that into context, I'm going to move this back. If you look at it in the Scottish data, it equates, a readmission rates compared to about 1 month of ED attendances across Scotland, or 3 to 4 months of admission to Scottish hospitals. Now, this isn't an acute medicine phenomena, but acute medicine is part of this. And we want to show that acute medicine is not exacerbating this problem. In reality, some of the higher readmission rates come, believe it or not, from the longer stay wards. But because of the volume of admissions through acute medicine, it is a contributing factor. But again, on a positive note here, I'll move this over here. This is the growth, going back to teaching, this is the growth in conferences attendances in acute medicine. You can't see the scale there, I'm sorry about that. I'm just going to go back one. But this is well over 1,000 now, and it's growing. This was actually, this was around 1,000 back here. So there's a gradual growth over about the first 10 years. And then with the introduction of COVID, introduction of webinars, the popularity of the society is growing. So the number of people attending training programs has grown dramatically, and that's a sign of a healthy specialty. And this just relates to that. This is evening updates being built on webinar programs like this, where acute medicine has got the opportunity to speak to a different group of individuals, becomes important as well. And then, of course, there's all the other aspects of acute medicine, including the specialty certificate examination as an exit program. I wanted to come back to acute medicine, though, as a teaching environment. And if you take the technological developments we've got, then on the right here, you have an old X-ray box with an X-ray showing the heart the wrong way around, never a good sign. But the reality is that we used to take X-ray boxes around. Now, they've disappeared quite some time ago from ward rounds, but most organizations have, computers on wheels or similar, where we can actually take the images to the bedside so we can help teach patients around aspects of the imaging, or we can use it at the same time to demonstrate to medical students in real time, this is what we found clinically, this is what the scan showed, etc., etc. So we can bring the technology to the bedside in acute medicine in a way that other specialties can't do it, because we can probably do it on every single patient that we're seeing, should we have to do it. And the same, of course, with bedside ultrasound. It's bringing a technical skill to the bedside where both the patient and any trainee can actually be working together and learning together. So acute medicine is actually a healthy specialty. 100% fill rate in 2020 for acute internal medicine training. There are around just under 260 trainees at ST5 or registrar level in the UK. It remains a growth specialty. And again, going back to one of the questions, you've got the opportunity to link it to subspecialties. Toxicology, intensive care is relatively popular, but small numbers of people do it. But there's no particular reason why people don't or couldn't dual credit in respiratory or other medical specialties, which some of us did historically. But those opportunities still exist today and should be encouraged, because that way we refresh the gene pool in acute medicine. So, and again, you've heard from Stephen about acute medicine. I'm sure any of us could give a long delivery, but acute medicine has a long history of being involved in ambulatory care, and same-day emergency care and COVID actually have given acute medicine a real opportunity to actually use the facilities that are available, use the staff that are available. And that's particularly true in England, although it's happening in Scotland as well. But there's lots of opportunity for people who want to get involved in the use of technology, infusion pumps for outpatient antibiotic therapy, lots of areas like that. But again, just going back, that we do need to make sure that we have good data for this, and that's a challenge for same-day emergency care at the minute, because the data definitions and how we record it is difficult. But at a local level, we can record our own data and therefore understand what we're actually doing for patients. And then the other thing, if you're looking on this on a kind of international basis, is to look at the Sustainable Development Goals as well, and look at how does it apply to any specialty. Well, actually, if you're looking at acute medicine, and this would apply to many specialties, though, we should be part of a good health and well-being system. We should be providing quality education. We should be looking at gender and other protected characteristics equality. We should be involved in high-tech innovation, and we should certainly have a moral obligation to our patients and our staff. So if you look, it's sometimes worth thinking about these things on that kind of bigger picture as well. So potential options for the future. I think the Society for Acute Medicine is a flourishing society, and for those of you who are considering acute medicine, wherever you are in the world, it doesn't do any harm to join the society, and they're now doing webinars like yours all over the world. There's a huge opportunity to engage with medical students and other professional training groups. It's probably one of the places where you can still promote and apply your clinical acumen in an emergency situation on a regular basis. It is growing internationally, so the opportunity to form relationships and build bridges between different countries and different units becomes there. Data is important, as I've already mentioned earlier on today. But importantly, for anybody thinking about be positive, but be realistic and provide that clinical voice, because being an advocate of clinical medicine, I think is very powerful for patients and carers, but students and undergraduates recognize clinicians who have that component as part of their overall development and the way they present themselves. So thank you very much for that. I've probably taken my 20 minutes, unlike Stephen, who was there, but there should be plenty of time for questions. Thank you very much.
Thank you very much, Professor Bell. Excellent talk, really enlightening, very informative, very inspirational. We have
I have the questions, Naseem. Thank you very much, Prof. Bell. Thank
question,
you, Stephen. So lots of interesting questions there. So shall we just actually start with the first question? I'm happy for any of you to come actually take this question. That is basically on why choose acute medicine? What is it actually with acute medicine when you've got other specialties like respiratory, gastrorenal doing the specialty job? So why kind of actually what really, I know, Prof, you've touched upon this and you've actually explained a lot about the journey and obviously the acute medicine as such, basically in its whole perspective. So why the trainees of today to kind of actually choose acute medicine over other specialties? Thank you.
I think the question is that why do acute medicine when I can do respiratory and gastro as well as acute take as a part of my job and have the best of both worlds? Why go full time in acute?
Stephen, do you want to go first on that one?
Yeah, so I think to answer that, you really have to understand acute medicine is a specialty in itself, and I think you find acute physicians will manage patients coming on the acute take very differently to a perfectly competent colleague who works mostly in gastroenterology, for example, or cardiology, and then does a post-take ward round post-take, of acute admissions. And I think if you're the kind of person that enjoys to, as Professor Bell said, to use your clinical acumen, use your foundation skills, your clinical examination, your history taking, your formulating and finding the correct working diagnoses, providing initial management, and thinking along the lines of, does this patient need to stay in hospital? Can they be managed on an ambulatory pathway? And all those things, then acute medicine's for you. If you have an interest in a particular organ systems, the way things are going, a particular specialty, but you still want to do a bit of GIM, there's still opportunity for that. But I don't think certain colleagues may not have the same degree of ownership of the acute medical units, the acute medical take. They may not think, well, they probably won't think in the same way along things like ambulatory pathways, which are actually much better for a lot of patients. But they can do the job perfectly competently. That's my take on it. I don't know what you think.
No. Am I muted? Am I muted? No, I'm not muted. I'm not muted. Sorry, I'm having a Sunday night, Zoom moment there. Similarly, I think if you think about the case mix of patients admitted to hospital and internationally as well as within the UK, a proportion of patients come in and they've got a clear diagnosis that's there, and we can all detect it. So say it's it's a lapsed chest physician, say it's pneumonia. Well, an uncomplicated pneumonia, an acute physician would be managing and probably has a different risk level because of again, going back to Stephen's point about the environment you work in. It's a safe risk level, but you're looking to see, can this person go home? Can I manage them in an ambulatory fashion? And if you can't answer those questions and can I get them home the next day, you're still doing that. But if you think you can't get them home, say it's not a straightforward pneumonia, there's a significant parapneumonic effusion that might require a bit of workup, might require bronchoscopy or CT that's going to take a bit longer. you might pass that, you might ask the chest physicians to do that. So you still want an acute medicine to have that appropriate input from specialty, but from the specialty point of view, it's because you think they're more complex and going to require longer in hospital, rather than referring them on to home, or indeed an ambulatory care pathway, which may well be managed by acute physicians these days as well. So there's a little bit for me around recognizing that if you don't have a clear diagnosis, it takes 24 or 48 hours in the people that you don't have a clear diagnosis to get your cross T's and dot I's. That's when that's when your second phase clinical acumen comes in. And I don't know quite what's wrong with you. I think it's respiratory or cardiac, but I'm going to need to do a bit more and then sort that out. And once you've sorted it out, what you don't want to do is put the person with you think it's respiratory, put them into respiratory, and then it turns out it's actually heart failure and they're in the wrong place. So we've got an important role to guide people into that, working with specialties. So it's a slightly longer answer, but hopefully try to sort of embellish really, what Stephen had said, which I totally agree with.
I think one of the things as well is to sort of focus on the acute problems, isn't it? So I think to move patients effectively and do the right thing for the patient in an acute medical unit, we focus on what they've come with, what's most important to them, and what they want to happen about it. And this is coming along to the care of the elderly side of things. I think you can't do acute medicine without being pretty much a pseudo geriatrician, and certainly have an interest in care of the elderly, because a lot of the patients are well over 80, well over 90 now that we see. And it's that sort of holistic approach and looking at how far you want to go with things with regards to investigations, correcting numbers, and what's actually in the patient's best interest. What do they want to happen? And I think acute physicians are much more mindful of that than perhaps a general physician coming on in the evening take, for example.
And I think can I just pick up just really about sort of the background? I think when we developed acute medicine, and before it was actually a specialty, one of the main concerns by the physicianly body in general was that acute physicians would burn out, and that they wouldn't after X period of time they'd burn out. By and large, that's not proven to be the case, but it is a specialty which you probably are more likely to thrive if you like making rapid decisions and being part of that continual buzz. But going back to Stephen's point, you've got to design rotas that are humane so that people get the downtime and then can come back and reflect. But yeah, so you tend to think on your feet quite a lot. But so yeah.
I think just actually leading to from where Stephen you've left about the acute medical assessment unit and having a general geriatric assessment unit. Do you think that hospitals actually should have two separate units, one for the elderly, one for the acute medicine? Because I think some units are actually working as such in the country, but I'm not sure whether each hospital in the country has got two separate units.
Yeah, so we talked about this a few years ago at Wigan. And I remember having a conversation with the chief executive at that time about A&E, and we kind of split it into three. So we've always had a paediatric A&E, haven't you, for a long time, because we recognise that poorly children are different to poorly adults. So we have a paediatric A&E, then we had an adult A&E. And then we decided that adult A&E can be split into two. So adults with serious medical problems or serious clinical problems, and adults with minor injuries. And the first thing we did was move minor injuries out of A&E. So that's in a different part of the site, a different building. The next thing was we thought, actually, in A&E, there's actually very, very broadly, this is probably oversimplistic, there's two types of patient. There's the frail elderly people who've come to A&E because they haven't really got anything acutely wrong with them as such, but they can't be at home anymore safely. And there's everyone else. And we thought these people shouldn't be mixed into the same pathway. And the actual traditional A&E pathway of junior doctor or registrar seeing them, stabilising them, etc., doing tests, isn't what they need. They don't really need blood tests and scans and things. They need to see therapists. They need to see a geriatrician or physician who can have a sort of holistic approach to their medical care and maybe just fine-tune their chronic condition management. So we split that off, and we've actually got a separate building called our Community Assessment Unit, or CAU, which is actually on our site, but it's run by the community arm of the division as such. There's some physician oversight, but it's mainly run by consultant AHPs and therapists, and patients are streamed into there as well. And that does work, because the wrong thing is for those people to get sucked into the system, end up potentially as outliers on surgical wards, staying in hospital for weeks, picking up hospital-acquired infections, having falls, getting delirium, when actually there's a different way we can manage those patients. So there's definitely a role for it. I think just as we work closely with emergency physicians, acute medicine will start working more and more closely with care of the elderly and frailty teams as well. And I think you should have a separate frailty. We did trial having a frailty unit on the AMU. It didn't really work because there's a lot of confusion about who goes where, and you couldn't necessarily ring fence those beds. You end up with very acute young patients in the middle of the frailty unit, you know, overnight, and it all got a bit messy. So I think separating it geographically and staff-wise is probably the way ahead.
Excellent, thank you. The question that's actually been asked certainly kind of quite a few times in the chat box and the Q&A box is about the working relationship between tertiary hospital and district hospitals, and I think some of the staff actually find it really stressful when they've got a patient on the acute medical unit and then trying to kind of actually refer them to specialists who do not work in that DGH, especially if you've got a neurosurgical patient coming with cord emergencies, or you've actually got a renal patient, you have got a renal unit or renal bed base, and you've got to transfer them to a centre. So how do you kind of actually tackle such difficult conversation, especially for the trainees, and also, you know, what's the role of the consultant there to kind of actually sort of facilitate early and timely transfer of the patient, the best possible sort of care in the best possible way at the right time? Thank you.
So, go on. I'll let you go.
No, you can go. I suppose I'll do it quickly. I think there's a couple of things here. One is that when I've established acute medical units, there's a bit about establishing a working relationship with the specialties who work within your hospital. What do you expect from cardiology, respiratory, renal, care of the elderly for that matter? And actually having that dialogue so everybody understands what happens within your own hospital. And then when it comes to what do you have to transfer off site, I think you have the same conversation to say that, you know, every whatever, you know, twice a week we'll have a subarachnoid hemorrhage patient who we know it's a subarachnoid hemorrhage, and we want them to go, you know, so you should be able to have, I think it's not easy, but I would start off with developing MOUs with the relevant with KPIs that, you know, which is what the ambulance service do with the hospitals now in terms of coming in. But I think you've got to do it within your own hospital first. What is your relationship with ED, respiratory, intensive care, etc. Certainly for the specialties that are an everyday occurrence, so respiratory and GI, but think about how you would do that in terms of onward transferring. And if anybody's fixed neurosurgery, that's a different question. Stephen, over to you.
Well, do you know what's actually transformed our relationship with neurosurgery is not having to speak to them anymore, because we've got an online
automated referral. Yeah.
So we don't actually have to have those conversations, thankfully, anymore. It's a bit more a bit better when we just type messages and they type them back. But we've got that as well for renal, and that has really helped. So it comes back to, like you just said there, having actual conversations, because for renal, I think we've gone on for years struggling to get patients to Salford Hospital, which is our local renal unit. And no one had actually sat down and spoken face-to-face with the renal physicians and asked them what their problems were in regards to transferring patients in. And you know, they would say to us, when I actually had those meetings with them, they'd say, well, we've got loads of really inappropriate referrals, and then they're stuck then in our tertiary beds, and because they're in Salford, we haven't got the access to social services in Wigan. You know, they block our beds essentially for ages. So that was made them really unhappy. They got really wary of taking anyone. And they've got few beds, you know, they cover a huge area, huge number of patients referred every day. And again, we set up a sort of pathway, we set up a service at Wigan to sort of try and filter out patients that wouldn't be appropriate to go there, and only then have the appropriate ones go into them. And we managed to develop an in-reach service, so they actually appointed 2 new consultants who part of their job plan was to do a session in Wigan in the hospital and a session in Wigan in the clinic. So it's all about just building it takes time though. It's not something you can fix. If you've got a particular specialty that a hospital has got difficulty with, it's not something you can fix overnight. It's something that takes time to build relationships and build pathways, but it can be done to a degree. I'm not saying it's perfect now, but it's better than it was.
And just picking up on the handover, because it's the same sort of question that's there. I think this also comes down to the size of organisation you work in, doesn't it? If you've got a small organisation, you've got a one-to-one relationship, perhaps with the chest physician that's on board. But when you get a bit bigger, it becomes more difficult. When you actually move to a tertiary or a quaternary hospital, the volume should be such that you can establish in relations that respiratory will visit twice a day. Cardiology will visit twice a day because they're bulk specialties, but neurology might only visit once a day, but you want them to visit at a predetermined time, not at a random time, so you can make sure that you can have the conversations, because that avoids some of the handover questions you've got if you're actually doing it in real time, face to face, as opposed to, I'd like respiratory to come and see this person. So yeah. Yeah.
I think we have 2 more questions, Mansoor, and 2 more questions, and then we'll conclude.
One question was about SAMBA support. I think
there's a question on recognition of acute medicine as a specialty in other parts of the world can be a problem if acute consultants plan to relocate abroad. I think maybe they're talking about recognition of CCT in acute medicine, something like that. So any comments? I think, Derek, you mentioned that other regions, other parts of the world, they are also they have started looking into establishing this as a specialty. Any thoughts?
Yeah. So I mean, this really came from when I was a president of the College of Physicians. But so places like Singapore, I think there are 8 to 10, or certainly 8 regional hospitals, including NUS and stuff in Singapore. They all have an acute medical unit. 7 of them actually perform in a very similar way, very similar structures. One is very different in the sense that it will only take level 1, the sicker subgroup of patients. So they stream that off. So acute medicine, they've got an acute medical group that's quite active. Malaysia has got acute medicine, but it's patchier. And as I say, in Bangladesh, they've developed those pictures I put. Bangladesh have got. In Dhaka, I've got it, and in Rawalpindi, in the military hospital, they're developing acute medicine. And often they see it as something that's responding to the needs that they've currently got. So it's actually a similar journey to acute medicine in the UK. But I think the one thing that does differentiate, and I've not done it, I didn't do it for today, but the hospitalist movement in the States does not have a defined geography. It's almost a hospital without walls. Whereas for me, you do need the safety of the geography. It's where your multi-professional team meets. It's where you have your ultrasound machines or your blood gas machine. You're in control of your environment, and that environment becomes important from that point of view.
Thank you.
Thank you. I think there's a question about SAMBA support, and Naseem, Prof, if you could just elaborate on SAMBA, I think.
Yeah, so SAMBA is the Society for Acute Medicine's annual audit program, which was bought out of the research program. I'm not up to speed with it now, but it does provide an annual review for all participating units. If you were outside the UK, my suspicion is they wouldn't object to you doing the audit on the day, providing you could actually answer the questions from that point of view. But I think the crucial thing there is using the audit to inform a unit's development or where you go in future, where it's appropriate to do so. And it gives you an idea of where you sit within, a peer, a group of peers. And it's a safe place to be, I would argue, Stephen. Is that you happy it's a safe place to contribute to?
Yeah, absolutely. It's I find it really useful, actually. Getting our local data, it really identifies the bits of the whole acute medicine journey that you need to focus on for the coming year. Yeah.
I think it's a really exciting and interesting talks of actually what you've said, Prof. And Stephen, because I think some of the trainees would consider acute medicine as a dumping ground where no other specialty, they don't want to take patients, they would actually sort of refer them or send them across to acute medicine. But I haven't actually seen the case, because I think you're the forerunners, you're the front door of the hospital, you can actually see the patient, sort them out, and then you refer them across to the specialties. So I think this should be enlightening for all the trainees who've actually heard and listened to the talk today.
Yeah, and I think it's a bit about being, being there to pull patients, not there to tell. You'd rather see the patient and move them, into an ambulatory forum or suggest an alternative, rather than wait 12 hours and suddenly get them on your patch. So it's especially where you want to be visible as a professional group, but then by being visible, it gives you more influence and more choice as well.
I think we have one last question, Mansoor, which is quite interesting. I'm not sure if there is any actually research done on this, but personality type, can anyone and everyone become acute medic, or there are certain personality traits? Somebody said fast decision making, quick thinking, dynamic actions, tolerance to continuous drama. Are there any personality types, Stephen, Derek?
I think there's a much broader spectrum of personality types in other specialties. That's a nice diplomatic answer.
Yeah, well, yes, you've got to read that answer very well, carefully though. I think that as in acute medicine, I think, Stephen, you mentioned you've now got 13 consultants or something. Yeah. Is that right?
Yeah.
And I've just written an article, a kind of a personal journey for the SAM journal. But when I moved back to Edinburgh as part of, many years ago now, to help develop acute medicine, I had 32 consultants on the rota, all doing a consultant of the day. That was too many consultants, and not very many of them were actually appropriate. They weren't skilled to do the job. And I think, so therefore, what I would argue there is that what you're looking for is a competency-based system. And as you recruit more consultants, you're looking to recruit to the gaps you have in the service. So you're seeing it as a series of building blocks. You're not necessarily recruiting people like yourself. So if I'm a lapsed chest physician, I don't need 3 other lapsed chest physicians. I need a renal physician, a gastroenterologist, or a care of the elderly, people who are interested in other aspects, or education, or innovation. So you're always looking to try and build up the team. When you're just 1 or 2 of you, it's tough gig, but once you get to sort of 8 and above, you're probably in a situation where you can create a team. And creating a team would probably be my last message for today. It's very much around creating a high-performing, functional team where everybody trusts themselves, and the goal is to provide the best care you can.
I think just one kind of actually interesting question from an audience about COVID affecting acute medicine. I know a lot of COVID patients actually, in some hospitals, the hospital I worked at, usually they go to the COVID ward from A&E. How did acute medicine actually cope during the pandemic for the last 2 years or so? With COVID, have you had COVID sort of bays, or have you had actually, or did you sort of transfer those patients across to the COVID ward? Did you have to cover COVID wards as such as acute physicians?
Steve, do you want to answer it from a personal perspective?
Yeah, so from a personal point of view, over the 2 years, it's changed a lot, to be honest. Right at the start, we had basically all of the consultant body pooled together, and we had a COVID rota, which was drawn up in sort of very much an emergency way, of 3 days on, 3 days off, and all the wards were split between people who sort of buddied up. We did have then moved to a sort of designated area. We've got a respiratory unit, and all of the COVID patients were cohorted there. A&E was split from the start into a COVID side and a non-COVID side. So anyone presented with possible COVID or known COVID went into obviously the COVID A&E, everyone else went into the other one. You can't guarantee you're splitting it that way, because people end up in the wrong one by the way they present, but it sort of reduces the risk, I guess, is the one thing. I think it was all very different. It impacted on acute medicine right at the start, because normal acute medicine, if you like, kind of disappeared for a few months in 2020. No one presented with non-cardiac chest pain. No one presented with funny neurology. No one presented at all. It was literally COVID or nothing pretty much for March, April time, I would say. because I covered one of the bits of AMU for non-COVID presentations, and we're pretty empty, I've got to say, for quite a while. But then obviously after things tailed off with COVID, things started to pick up again, then it came back again. So it's all, I think the way acute medicine has worked, it's varied, and the impact on acute medicine has varied according to what part of each wave we've been out of the pandemic, really.
Yeah, just a final word for, I mean, acute medicine, I think we, as I said, did a brief study of some of the units in the UK and Singapore and Netherlands. And I think what I would say is acute medicine always had a significant part to play in the response to COVID. That varied by hospital, and to some extent it varied by the geography of a unit, or whether respiratory took, you know, all the COVID patients, what the respiratory unit was like. And certainly where I worked, it was a mixed response. Acute medicine, respiratory took the bulk of it. We created a COVID ward, and then we managed the patients jointly, and the acute medical unit stayed non-COVID, as Stephen's describing. But it was, the models varied around the country, and some of it is just geographical limitations, you know, not enough side rooms or whatever the limitation was. But undoubtedly acute medicine had a significant role throughout. And I think, well, again, I think one of the things during the debrief from all this is working at what we do if we get, you know, disease X, as COVID was, if you know what I mean. Yeah.
Thank you both, thank you. Naseem?
Yes, Mansoor, you conclude the session, yes?
I think, yes, thank you very much. I think excellent, exciting and fascinating talk by both speakers. Thank you, Prof. Bell, and thank you, Stephen. I'm sure that this is all recorded and for sort of audiences to go back and listen to the talk later on. We have got no sort of webinar in April due to the holy month of Ramadan. We'll be back in May, so we'll see you all in May. Thank you very much.
Thank you very much. Thank you.
Thank you.
Thanks for the invite, and then have a good evening or day, morning, depending on where you are in the world. Take care.
Thank you. Thank you. Bye-bye. Bye-bye.
Thank you. Bye-bye.
Bye.